Hello everybody, my name is Akriti Soni and I'm one of the second year internal medicine residents at St. Vincent Hospital, Worcester, Massachusetts. I would like to thank the Massachusetts chapter of ACP for allowing me to present this interesting case today. An aberrant vessel hidden in plain sight in our gastrointestinal mucosa, notorious for causing a GI bleed that is hard and sometimes impossible to catch. The Dieulafoy lesion is a rare cause of an upper GI bleed, with an incidence of 1.6 in 100,000 people. It is a large caliber submucosal vessel that leads to pressure necrosis of the overlying epithelium. It is most frequently found in the stomach and infrequently in the cecum. The duodenal Dieulafoy lesion constitutes 10 to 15% of all cases. It can be seen in any age group. However, incidence does increase with age and is especially common in the 6th and 7th decade. As age-related gastric mucosal atrophy is a common pathophysiology behind it. Our case is a diagnostic and therapeutic conundrum of a 47-year-old man with a history of chronic liver disease who presented with dark stools and coffee ground emesis. His vitals were stable initially and physical exam was unremarkable. However, his labs showed a significant drop in his HNH from 11 and 30 to 5.5 and 19. Guideline-directed management with getting an IV access, liberal fluid resuscitation, and an octreotide drip was started. The patient also received 2 units of packed RBCs. An EGD revealed portal gastropathy with no evidence of an active bleed. He continued to have persistently dropping hemoglobin, despite multiple daily transfusions. Eventually, his care was escalated to ICU given his hemodynamic instability. The patient underwent a myriad of investigations with an endoscopy, a colonoscopy, a capsule endoscopy, and a CT angiography. However, none were able to identify a bleeding source. The capsule and a tagged RBC did, however, show bleeding in the duodenum. The patient underwent a repeat EGD, which showed fresh blood between the bulb and the second part of the duodenum. Upon flushing, active pinpoint bleeding appeared from a deeper vessel that was intermittently spurting. This vessel was hemoclipped, as shown in the image. Despite this, the patient continued to have persistent bleeding, and hence a gastroduodenal artery embolization was performed. During the course of the hospitalization, the patient received a cumulative total of 28 units of PRBC, 6 units of FFP, and 2 units of cryoprecipitate. Despite this, his HNH continued to drop. Eventually, he was taken for a partial resection of the duodenum to prevent any further episodes of bleeding. The spectrum of disease presentation for a duodenal Dieulafoy lesion ranges from asymptomatic anemia to frank hematomesis and melena with hemodynamic instability. Due to the superficial presence of this large vessel with overlying ischemia, even minor trauma, either from food or alcohol, can completely erode the epithelium. And depending on the caliber of the vessel, the bleeding can be massive. Endoscopy is the mainstay for diagnosis and treatment. However, it can be very difficult owing to the lack of any mucosal lesion and the intermittent nature of the bleeding. Proper timing of diagnostic tests is crucial, and several attempts are necessary in some cases for diagnosis. Like in our case, the patient received a total of 3 endoscopies, 2 colonoscopies, 2 capsule endoscopies, a tagged RBC scan, and a CT angiography. In most cases, endoscopic epinephrine injection followed by thermocoagulation with or without clipping helps control the bleeding. Some cases do require an angiographic embolization. However, there are less than 5% of cases where medical treatment is not successful and surgical resection is necessary as a last line of therapy. Thank you, and I hope you liked our case.